This is a live recording from Radiopedia.org's 2015 Emergency Radiology course in Melbourne, Australia, featuring Dr. Andrew Dixon and Dr. Frank Gaylard. For more information about Radiopedia courses, visit radiopedia.org/courses.
Okay, welcome back. We're moving on to the chest and then the abdomen session. It's going to be a little bit more heavy on CT imaging, but still with the chest we do a fair bit of plain films. I just wanted to mention that obviously we're recording the event today for people overseas, but you guys all get access to the video as well. It'll be out on June 1, so free access to the video. So if you feel like things are going through very quickly or you want to go back or you phase out for a little bit, then just go back and watch the video. Also, when you've got the playlist there on the site, you can go through every single case. There's a few more cases in the playlist than there are actually presented today. You can look at all those. There's findings and there's descriptions and there's often quiz questions with them. So the whole experience is really more than just sitting here and listening today, going home and going through the content again. All right. So the chest. The non-radiologists often have this idea that if I just knew the checklist of what to look for, I could be a radiologist. And the answer is, it doesn't matter how good your checklist is, if you don't have any idea about the pathology, then you're going to struggle to find it. Okay, so I'm not going to go through a systematic look at this, look at this, look at this for a lot of these chest and abdomen things, all right, because that would just take too long for each case. You should have a system of looking. You know, with this film, you should be looking at the hemidiaphragms. Okay, you should be looking at the margins of the mediastinum, and you should know what they all correspond to. Okay, but what I'm going to try and teach you now is how to recognise some pathology using X-ray and CT in the chest. There are a few things I do want to point out, and I think the mediastinal contours are not really as important as knowing the lungs and what the lungs look like. You've got black air sitting in the lungs, and you've got these nice little white vessels coursing through the lungs, and they go all the way out, just almost to the periphery. Okay, you should be able to trace these in every patient, from the hilum in here, all the way out to the periphery of the lung. Okay, if you can't trace those vessels, it means that there must be something of the same density as those vessels sitting around them. Okay, and it should be air, so it should be able to see them. You can only see an interface between two structures if the density between them is different. If the density is the same or roughly the same, then you're not going to resolve that interface. This is the key to identifying airspace opacity within the lung. It's the key to identifying, localizing where things are using the silhouette sign with the mediastinum. Okay? If two things are the same density, you don't identify the interface between them. If they're two different densities, you'll interface beautifully. Okay? Here you see that the liver sitting underneath the heart, there's no interface between those two because they're the same, very similar density. All right, you can see the intervertebral disc there kind of creating a little bit of a density difference, but you can't see, even though you know the diaphragm continues right across the midline here, you can only see it out here where air is touching the diaphragm. As soon as the heart sits directly on top of the diaphragm, you lose that interface. Okay, and we can use that to help us localize where pathology is within the lung. If we lose an interface, we know those two things must be touching each other. On the lateral image, I just wanted to point out the vertebral bodies. As you come down, they should get darker over those vertebral bodies because you're traversing much more soft tissue. You've got the muscles around the arms at the top of the chest here, and also the chest gets very big towards the bottom, much more air relative to soft tissue. So this is a normal appearance. So as the vertebral bodies come down, you should be getting more black. Some people call it the more black sign. Okay, so that's a normal appearance. On the lateral, you can see both hemidiaphragms. Okay, that means there must be air sitting directly next to the diaphragm. If you can only see one hemidiaphragm, then there must be something of soft tissue or fluid density sitting next to it. So just to emphasize that, here's the black. The black is the lung, and this is my attempt to, it's really a tree, but this is the blood vessels moving through the lung. As I said, you should be able to trace them very, very easily on a normal chest radiograph. Okay? As soon as you start to see airspace opacity arising, so the alveolar space is filling up with pus or fluid or hemorrhage or proteinaceous material, Okay, anything, you can't really tell the difference between them. Once it starts filling up, you'll lose the ability to trace the vessels through there, okay, because it's very similar, the fluid or the pus is a similar density to the vessels, and you'll start to gain the ability to see the airways moving through there, so bronchograms. And the more you have, the more obvious that becomes, okay? So this is the same thing as the silhouette sign, it's just on a much smaller scale. Relative density difference tells you what there is, okay? If you're looking at a chest x-ray and you can't trace the vessels from the hilum, okay, but you can trace some black branching things, then you've got some airspace opacity in there, okay? Simple as that. Fever and shortness of breath in a 32-year-old female. So we're going to put this into practice, and we're going to say there's obviously an opacity in this mid-zone here, okay? And when we look at this opacity, obviously we can't trace the blood vessels through there anymore. I'll just zoom in, sorry. Can't trace the blood vessels, but what you can trace is maybe some little black branching things. You see that there? Black branching thing. So you know that this opacity can't be in the pleural space. It can't be on the chest wall. It must be within the airspace because it's surrounding these bronchi and outlining them and letting you see them, okay? Then the other thing we see in this patient, so there's a consolidation is the other word for it. So an airspace opacity, a consolidation, alveolar opacity, lots of words that kind of mean the same thing. Okay, so some consolidation. And then we look at the interface with the mediastinum. You can see a beautiful hemidiaphragm here. The left heart border, however, is very hard to find. You can see the right heart border. Left heart border, barely can tell where it is. That helps us localise whether this is anterior or posterior within the chest. The heart is at the front and it has the left upper lobe lingula sitting next to it, okay? If this was in the lower lobe, you'd be able to see that heart border perfectly clearly, okay? Because it's not directly touching each other. This consolidation must be directly touching the left heart border, therefore it must be within the left upper lobe. That's the silhouette sign or the loss of the normal silhouette. On the lateral image, much easier to identify that this is in the upper lobe. You can see the oblique fissure outlined perfectly, nice lower lobe, vertebral body's getting more black as they come down, and there's this opacity sitting up here above the oblique fissure in the upper lobe. So from CT point of view, just want to do a little bit of anatomy, but not too much, because it does take some time to learn all of the structures. But in terms of the lung, the lobes, identifying where the fissures are, the fissures don't, blood vessels are not going to pass through a fissure, right? Because it's a segmentation between the two. There's a pleural reflection there, okay? So this is where the fissure is. See how the blood vessels come out and then they all stop there? And the blood vessels on the other side have all stopped. So when you're trying to identify a fissure on a CT, you're looking for the spot where those blood vessels suddenly stop. It's very hard to spot it. See a fissure coming along here? All right? That's how you find a fissure. Here's another fissure through here. That's the oblique fissure. That one coming through there is going to be the horizontal fissure. All right? But if you look on, if you look on the coronal images here, you're going to see exactly why in how we can localise things. Okay, so this is the upper lobe here, lingular portion sitting right next to that left heart border. As we come back, see the oblique fissure coming up? So this is lower lobe. Lower lobe is not really touching the heart. So it's here, it's sitting right at the base of the heart, okay, but it's touching the hemidiaphragm, okay? So if you have consolidation in the left lower lobe, you're going to lose that left hemidiaphragm ability to differentiate it on your plain film. Okay? If you have consolidation in the left upper lobe lingula, you're going to lose the ability to see that left heart border. Right middle lobe, same thing. Horizontal fissure here, oblique fissure coming through. This is all middle lobe touching the right heart border. So all of the right heart border is due to the right middle lobe. But you can see the fissure comes across here, right? And all that hemidiaphragm is in the lower lobe. Okay? So lower lobe, you're going to lose the hemidiaphragm. Middle lobe, you're going to lose the right heart border. Upper lobe, you're mainly going to lose that interface with the upper mediastinum. All right. The other thing I want to talk about with anatomy of the chest is the importance of, this systematic approach for the chest is to go through the lung fields, look for any consolidation, any nodules, look for a pleural effusion. Then you want to assess the mediastinum. The mediastinum is mainly just the great vessels and a trachea coming down and an esophagus here at the back. Everything else in the mediastinum is just fat, okay? And as I said elsewhere, fat is your friend on CT and on plain films. If something is abnormal in the fat, it's going to be closer to fluid density or soft tissue density it's not going to be nice and black, okay? And you should have a nice black fat outlining all of the organs, all of the vessels. Okay, so mediastinal fat is something I want you to concentrate on always looking at on your CTs of the chest. We'll move on to some pathology. So shortness of breath, fever and rigors. So we're thinking they've got pneumonia. And we look on the PA chest radiograph here. You can see this right hemidiaphragm perfectly clearly. Left hemidiaphragm you cannot make out at all. Now these, there's a generally increased density to this lower zone, so most people would probably spot that anyway, but there are a lot of left lower lobe collapses and consolidations that are missed in the emergency department because people think, oh, if you look behind the, the heart is supposed to be there, it's supposed to be dense, so I can't really assess that area, but you can. Let's go back to our normal. Behind the heart you can still see these vessels coursing through. That's the lower lobe. There's little vessels coursing all the way through there. Even below, through the liver, you can still detect vessels in that right lower lobe. So the fact that the heart is there is not an excuse to not be able to assess the lung that sits behind it, which is the left lower lobe. Okay, so let's get back to this case here.
Andrew, I promise not to say.
You promise not to interrupt.
But I can't help it. Because you ought to see the aorta.
You ought to see the aorta, that is correct. And what Nina is referring to is that the aorta is posterior in the chest, okay, and you can see it here outlined all the way down, but you can see it there. The lower lobe is of course located posteriorly as well, so you shouldn't be able to see it in a real left lower lobe collapse, but this one, consolidation must be slightly lateral to that margin. Is that what you're wanting to point out?
Yeah.
Yeah. So the fact that you can see it means there's not consolidation or collapse throughout the whole of that lower lobe, it's just partial. Okay, so it's more further out, touching the hemidiaphragm. On the lateral image, we see that loss of the more black sign. Okay, coming down, they're not more black, they're getting whiter down towards the bottom here. We can only see one hemidiaphragm, not two, therefore there must be consolidation directly adjacent to the hemidiaphragm, and we're seeing that oblique fissure outlined very nicely. So left lower lobe, consolidation, a little bit of collapse. Again, just another example of what it looks like on CT and why you lose that hemidiaphragm interface. Here's also why Nina says you lose your descending aorta, ability to see that. Okay, so if there was a complete collapse of that left lower lobe, you shouldn't see the descending aorta coming down. Okay, show shortness of breath in an elderly female patient. This is probably the hardest of the lobar collapses to identify. This is a left upper lobe collapse, and the left upper lobe collapses anteriorly in the chest, and the left upper lobe spans right from the base of the lung all the way up to the top. So when it falls against the front of the chest, it just creates this generally increased density throughout the whole of the left hemithorax. Okay, but you can see here you can't really see that left heart border, which is a sign that something is adjacent to that left heart border, but you can still see the left hemidiaphragm, so there's nothing in the lower lobe. Okay, you can still see those vessels traversing behind the lungs. What you do see is signs of volume loss in this patient. The hemidiaphragms come up. These ribs are probably tighter together than the ones on the other side. This trachea, which normally comes down fairly midline, slightly off to the right, maybe the mediastinum is pulled across just slightly in this patient. But the signs of volume loss, a generally increased opacity in that left hemithorax, that's a left upper lobe collapse. This patient probably has a mass tumour sitting in here, causing the left upper lobe collapse. If you have a patient just presenting out of the blue with a left upper lobe collapse, you've always got to do a CT to look for a cancer. Okay. If the patient's intubated in ICU, the most likely cause is going to be a mucus plug getting into the airway, blocking it off. But in just out of the blue, presenting with shortness of breath, a cancer is going to be the thing to look for. Okay. Asthmatic patients can sometimes present with a mucus plug as well in younger patients, but older patient presenting with left upper lobe collapse, this is going to be your tumour, lung cancer here. That's just the lateral film. So here's right upper lobe collapse. Again, we're talking about that interface with the right side, so the right paratracheal tissues look thickened. That's a complete right upper lobe collapse. Not a lot of signs of volume loss. Maybe these ribs are slightly closer together. This patient's got hyperexpanded lungs. They've probably got COPD in the background. This is a classic. This is a right upper lobe collapse. I might have said left for the last one. I meant to say right. This is a right upper lobe collapse due to a tumour sitting here centrally at the hilum, and it creates this reverse S shape. It's called the S sign of Golden, or the Golden S sign. Okay, and that is right upper lobe collapse due to an obstructing central mass. Again, lobar collapse in an elderly patient or an older patient presenting out of the blue. We're talking cancer. It's a acute sign. All right, this patient here, we can see they're presenting with cough and fever. Another good example of air bronchograms. Can't trace the white vessels, but I can trace these black branching structures through here. So there's definitely opacity in the airspace. It's not as if there's fluid tracking in an oblique fissure to create this. You know, it's not pleural. It must be within the alveolar space in order to create those air bronchograms. The right heart border is completely lost. Can't see it, but I can still see the right hemidiaphragm. So therefore, this is consolidation within the right middle lobe, a right middle lobe pneumonia. This patient, you can also see the horizontal fissure here being outlined by some opacity above it. The thing that sits above the horizontal fissure is the anterior segment of the right upper lobe. So you can give this patient right middle lobe pneumonia and anterior segment of right upper lobe consolidation. So here's all your consolidation in the middle lobe, beautifully seen on the lateral, and there's probably some patchy stuff just above the horizontal fissure here in the anterior portion of the right upper lobe. Okay, 35-year-old woman with cough and fever. What are the findings and diagnosis? The winner for this case was Chi. Where are you, Chi? Come down. Chi is one of my first-year registrars. And this was a tricky case. This is a case again where I show it to the registrars before they go to their exam, and beads of sweat sometimes appear. This has got presenting with cough and fever. Nice example of consolidation here with little branching black things, so air bronchograms. Starting to lose the left heart border, so we're thinking this is a left upper lobe pneumonia. But what we're also seeing is that the right heart border we can't really see. We can still trace vessels here though, right? Remember I talked about if you can trace the vessels, then you know that there's not any airspace opacity. Still trace the vessels, and in this patient they have...
They also have pectus excavatum.
Correct. So if we look, you can take a prize. You can take food or wine, whichever you like. So this is a trick case, because you automatically think, oh, there's consolidation, there's pneumonia here in the left upper lobe. Oh, there must be some right middle lobe pneumonia as well. Slam dunk. But what you need to appreciate is those vessels you can see traversing the area, the fact that the whole of mediastinum is shifted just a little bit off to the left, okay? And these ribs come out very horizontally at the back and then very steep at the front. That's a sign of pectus excavatum chest deformity on a PA chest radiograph. On the lateral, you can see it coming in here. That's the sternum depressed inwards on this patient. So the sternum comes in and actually pushes the heart off to the side. The increased density there is because it's traversing more soft tissue because of the way in which it fills with a little bit of fat in front of their chest deformity. Okay, so that's a little trick. Even though we had the lateral image for you guys to look at, vast majority of people said there was right middle lobe pneumonia in this patient. So don't forget to look at your lateral film and see if there's any consolidation in the right middle lobe, and also don't forget to assess the sternum on your lateral film to look for pectus excavatum. Here's the same patient after they've had antibiotics a few months later. So you can see that consolidation is cleared. You can now trace little vessels through here. You can see the left heart border again, but you've still got that I can't see the right heart border problem. You've got a vague density in this area, but I can trace the vessels. Okay, we saw a left upper lobe collapse and all the signs of volume loss that we had on that patient. This is a complete collapse of the left lung, and this is because the patient has an endotracheal tube and the tip of it is in the right main bronchus. The carina is around about here, so you can see that lucency, the bronchus coming off this way. So too far down, no air going into that lung, completely collapses down. But I'm just using this to emphasise, if you have the setting where you've got a completely opacified hemithorax, the key to working out what it is volume, okay? Is it reduced in volume? Is it pulling structures towards it? The trachea is pulled way across to that side, okay? The heart border usually should have 1/3 of the heart on one side of the midline and 2/3 on the left. This is all across in the left side of the chest. Those ribs, look how close these ribs are together compared to these big spaces on the other side. You can't see the hemidiaphragm, but it's probably sitting way up here, okay? So this, you know, is a reduced volume in that chest. It must be collapse of the lung in order to create that. If it was a big pleural effusion that's in this chest, pleural effusions have positive mass effect. They're going to push the mediastinum and the trachea away to the other side. Okay, big difference between the two. One problem is that they can coexist. You can have some effusion and some collapse. Usually if you've got a massive effusion, the lung is always completely collapsed, all right? So this one, you'd be pretty happy. Patient has ETT in the wrong spot, caused a complete collapse of the left hemithorax. You pull that back, it's probably going to completely re-expand and everything will be fine. Here's one kind of in progress. So here's an endotracheal tube coming down here, sitting just at the commencement of the right main bronchus. Here's the left bronchus coming off, okay? And you can see that you haven't completely collapsed that lung down yet, but you've got increased density in this left hemithorax compared to the right, okay? You've got the diaphragm coming up, you've got those ribs starting to come together, and you've got the mediastinum starting to move across to the left. So if you see a chest x-ray like this, you know that it's about to completely collapse. The air has to be resorbed, so it does take a little while for it to evolve. So looking for signs of volume loss, volume increase is important to assess hemithorax whiteout. Okay. We're moving on. Let me see if I can work out what this one is. A bit of a tough case. I'm not sure. Let's have a look at the findings. Now, there's always a, there'll be some point I'm trying to make here. Oh, nasogastric, sorry. I was looking at the lungs. You can always, when you go through these, there's findings, little options, there's often little questions, and there's a discussion which I've hidden for the purposes of today. But when you go on the website, you should be able to get all these cases. So this case, the nasogastric tube, when you're looking at that, it should follow the mediastinum and head down through the diaphragm here into the stomach. If it's following the contour of the trachea down the bronchus, then you're in trouble, okay? And I just want to emphasise how far down that costophrenic recess goes at the back. This is still within the lung. It may be getting out towards the very periphery of the lung out there. Nasogastric tube. I don't know what the protocol is at most hospitals. Here we always do chest x-rays. Other people do, you know, testing for acidity and things like that to confirm. But it's important that you confirm that your nasogastric tube is in position. Here's another one. This one's quite good. They've managed to go down the right main bronchus, loop around, and then go down the left. That's very skilled, bonus marks. And then we can see another abnormality on this one. Can't see that hemidiaphragm, okay? Can't see those vessels moving down behind the heart. We've just got a complete whiteness behind the heart. So we've got collapse within that left lower lobe, maybe a bit of consolidation. Okay, so you can't see the hemidiaphragm. This patient's got some density out in their costophrenic recesses, and they've got what we'd call venous congestion. These are all vessels that we're tracing here. Okay, they're just a little bit more prominent than most people. They may be supine, and that can be normal. If they're erect, if they're standing erect and they've still got these prominent vessels like this, then that would be venous congestion, a sign of fluid overload. The other thing that tells you there's positive or high venous pressure here is that azygous vein. See that thing sitting there sits right above the right main bronchus. Always sits there. It gets distended when you've got, you know, it's a marker of a JVP, same as a JVP. Okay, so if the azygous vein's dilated, it's a sign of high pressure. This is a PICC line coming in from the right arm, sitting in the SVC. So we're moving on now to do a little bit of pulmonary edema and fluid overload. This is your classic kind of patient presenting to ED with rapid onset, shortness of breath, looking terrible. And a beautiful example again of these inability to trace the vessels out of the hilum, okay, but you can trace black branching things. There's an airspace opacity. It's more prominent on the right than the left, but it is bilateral. It's very central, so it's perihilar is the term we often use for that. Some people use bat wing opacity. I don't really like that term, but perihilar is a good word for it. And the periphery is spared, okay? So it's mainly a central airspace opacity. This patient was doing very poorly, intubated. The mediastinal contour here is abnormal. We normally have the aortic knuckle up here, and then we have the pulmonary artery, the main pulmonary trunk. And here it's very, very dilated. So this patient actually had unrecognised primary pulmonary hypertension and then went into acute pulmonary edema from that. In terms of curly B lines, you can see them in this patient. The vessels, as I said earlier, they branch away and get smaller and finer towards the periphery of the lung, and in the last little half a centimetre, you barely see them, okay? In this patient, you can see these nice horizontal lines going all the way out to the edge of the lung. That is in the interstitium, not vessels. That's your interstitial edema, your curly B lines, okay? So fluid in the alveolar space, fluid collecting in the interstitium, creating these curly B lines. This is the beautiful correlation on the CT. Again, you know, why can't I trace those vessels? Because the fluid in the air spaces, in the alveolar spaces, is very similar density to the vessels. Remember, this has got contrast in it, so the vessels are normally not this dense. Okay, so you can't see the interface between those two, but you can see the interface between the black and the white. Okay, nice little curly B lines all out the side. You often, on a CT, I find the very apical slices to be really useful for identifying interstitial edema. See all these little hexagons? This is the secondary pulmonary lobule that's outlined with the septal lines at the edge of them. I find that if they don't have septal lines up there, they probably haven't got interstitial edema. Okay, so you'll find that's a fairly reliable kind of thing to look for. So all these things, not vessels. Vessels don't go out and touch the pleura. As we saw earlier, we knew the pleura was there because there were no vessels. These things are all interstitium filled up with fluid in a patient with acute pulmonary edema. And just to look at that, pulmonary artery is massive here, much, much bigger than the aorta. That's pulmonary hypertension. Okay, poll question. Get your phones out. So what are the potential causes of delirium in this patient? We'll try and zoom up a little bit. We'll just leave it there. And so the options are fluid overload. Well, we've been talking about fluid overload, so hopefully you'll be able to recognise whether it's there. Perforated bowel. We haven't spoken about free air under the diaphragm, but we'll have a look for that. Is there pneumonia going on? Have they got skeletal pain? I think you're allowed to select multiple for this one. So let's go back here. A few answers coming in. So fluid overload is the majority of people are recognising that. As we said earlier, this is an erect film. You can see that there's lots of vessels passing through this lung. There's venous congestion. The upper lobe vessels are very prominent. Okay, this patient's not supine, they're erect. They've got venous congestion, too much fluid on board. There's a big azygos vein sitting up over here as well. Okay, if you go out to the periphery, you get those little lines, curly B lines there, a little bit of fluid sitting in some fissures in the lung here as well. Too much fluid, obviously they've got a big heart. If the heart's coming out and touching the side of the chest, then you know it's too big. There's the ratio half of the chest diameter that you should be measuring. So this patient definitely has fluid overload. In terms of airspace opacity, they've probably lost the ability to differentiate some of the vessels coming out of the hilum, so there's probably a little bit of alveolar edema sitting in there. The other sign you're getting is peribronchial cuffing, fluid sitting around some of the bronchi. See that bronchus there coming out? It's got fluid directly around it. Often that's interstitial as well as a bit of alveolar outside it, peribronchial cuffing. So definitely fluid overload in this patient. We can't see any real focal, segmental collapse or consolidation to suggest that they have pneumonia. We can't see any air under the diaphragms to suggest that they've got a perforation, but we can see bilateral anterior shoulder dislocations in this woman. So very, very painful shoulder dislocation. I don't know if you've seen people in ED with dislocations, a lot of pain. This person's delirium was largely due to pain, I think.
Easily missed, though.
Easily missed. Okay, so just emphasise the ability to look, emphasise the importance to look at the periphery of the films. Okay. Okay, so this patient's had a recent chest infection, and this is their follow-up chest X-ray. We're moving on from the alveolar space. We're looking at consolidation and fluid overload, and now we're moving into then we looked a little bit of the interstitial space with the fluid overload, interstitial edema. Now we're moving into the pleural space. This is where the fluid moves, goes into the alveolar space, then it goes into the interstitium, then it goes out into the pleural space, okay? Everyone knows the meniscus sign of a pleural fluid, blunting of the costophrenic recess. As we've seen earlier, you should always be able to trace the hemidiaphragm, and it should come down to a nice point with the chest wall, with the ribs, okay? That's a normal sharp costophrenic recess. You have a look on the other side, there's no sharp costophrenic recess, and you've got this meniscus of fluid coming up there, okay? You can actually trace it all the way down the back, all the way here. You don't often see that, but this is just a very nice example of a fluid meniscus. If you take your hand and you've got a glass of water, you take your hand and you stick it in there, right? The fluid comes up around your hand, okay? And if your hand was full of air, all right, and you took an X-ray from the front, you're going to see the fluid coming up the sides as being more dense, okay? But the air is going to be in the centre. That's why you get that meniscus kind of appearance. It's important for recognising the difference between a meniscus like that, which means it's just pleural space with fluid in it, and a hydropneumothorax, which is an air fluid level, which is going to be a perfectly straight line. We'll see that in a minute. On the lateral image, you can see that meniscus at the back. The lateral image is more sensitive for smaller volumes of pleural fluid than the PA projection, okay? So meniscus at the back, exactly the same as at the front. This is another example of pleural effusion. This one's slightly different in that it doesn't have that nice meniscus, and it's, the diaphragm looks like it's in a good spot here and then it moves up, okay? One of the things that I think Nina taught me very first was that the diaphragm should have its peak towards the kind of mid-chest, the mid-clavicular line, and then it should descend back down again. If you have a lateralized peak, or the peak is right off to the side, that's a sign of a subpulmonic effusion. So the effusion is sitting down, trapped below the lung a little bit, and it creates that lateralization, loss of the costophrenic recess. So subpulmonic effusion, that's just a variant, the way that it can appear in some people. Lateral image, beautiful meniscus. There's probably pleural fluid on both sides in this patient. So fell in the bathroom, flank pain, 85-year-old male. All right. This patient, I think this is a good case. This is one from my trauma course, actually. This patient's fallen down. This is a supine film. Those ones we were looking at of pleural fluid there, the patient was erect. That's why the fluid sits down at the bottom of the chest. If the patient is supine, the fluid is going to layer along the back of the chest. It's going to be a bit like that left upper lobe collapse. You're just going to get that vague density throughout the whole of the hemithorax. When you initially look at this, you think, oh, has he got a big pneumothorax on the left, or has he got something causing opacity on the right? The answer with this patient is he fell onto the right. If you trace this rib, you can see that just does a little angulation there. See the top of the rib, and then a little angle, so he's had rib fractures. Okay, and he's got this general increased density to that right hemithorax. That's very suggestive of a hemothorax on that side. Okay, in the setting of trauma, you would call it a hemothorax rather than a pleural effusion. Again, I want to emphasise that you can trace these vessels. We've got white branching things all through this. Even though there's generally increased density, you can see the vessels because there's air right next to the vessels. If that was consolidation, airspace opacity, you wouldn't see the vessels, you'd see black branching things. So I'm thinking this is not within the alveolar space, it's covering the whole chest. The patient's supine, you get a CT and you see he's got plenty of blood sitting in his chest. When they're supine on the CT, it matches what you see on the plain film. It all sits at the back. Slightly increased density compared to normal fluid, so it's consistent with hematoma. When you have a look at his bone windows, you can notice some fractures of the transverse process here, fractures of the ribs, okay, fractures here, slightly more displaced down here, a rib neck fracture, displaced fracture here. He must have ruptured a little intercostal vessel there and he's bled out into the chest. One thing I often get asked is how ED guys not knowing the difference between a pleural effusion and atelectasis in the lung. We use the term atelectasis when we're talking about collapse. It's the same as collapse, okay? And the key is that atelectasis is part of the lung. The lung has vessels going through it. It's going to enhance. It's going to have vessels, okay? So you see here, see that bit there that's very dense? That's the lung being compressed next to this pleural fluid, okay? So that's a bit of atelectasis, and then that is the pleural fluid. No vessels are going to travel through your pleural fluid, okay? It's just a potential space. So almost always when you have a pleural effusion, you're going to have some what we call compressive atelectasis next to it. The key is there's little vessels in there and it enhances, okay? if you had this same setting and you didn't see the fluid and you saw this nice enhancing stuff all the way out to the periphery, then that's just going to be collapse of some lung, okay, without any pleural fluid. I think we'll see an example of that later on. On the lateral image, just a good example of meniscus again, okay, and why it looks like that on the plain film. So we move on to this patient who has cough and symptoms of a chest infection. This is a pleurally based densely, forming a bit of a meniscus like we saw before, but you'd expect the meniscus to kind of go across like this, okay? If it was just a simple pleural fluid filling up the chest. When you start to see it forming funny shapes like this and the patient's febrile, you'd be thinking, is this an empyema in the pleural space? Is this infected? And this turned out to be a big empyema in the chest. So just looking at the contour of it, does it make sense? Is it sitting perfectly the way gravity intends it? Or is it forming some funny contours? Here's a patient with empyema. If we go back to that patient that had pleural effusion, if you looked carefully, you'd see that there's no enhancement of the pleura. You can't see it. It's wafer thin, okay? In the setting of empyema, that pleura gets thickened and enhances, and you can see that really well on the CT here. See that thickened, enhancing pleura? Okay, it's the visceral and the parietal pleura that both enhance. There's a sign called the split pleura sign where the pleura comes and splits into two parts. That's all signs of an empyema. This has also got some air in it, so it's forming some gas. And just in terms of the contour, have a look. It's forming a bit of a lens shape. It's pushing on things. It's not sitting like you'd expect fluid to sit in a supine patient. So the enhancement of the pleura is the key, and the loculation or the funny shape to it. Aha. So here's thinking back to my son and his layered fluids and the air fluid interface at the top. Perfectly straight line inside the human body is a fluid or an air fluid level. Okay. So here you've got lots of fluid in this right pleural space. You might call it a pleural effusion, but because it's a perfectly straight line, you know that it must be an air fluid interface, therefore there must be air in the pleural space. Therefore, this is a hydropneumothorax, okay? If you look, you can see the pleural edge, the lungs completely collapsed down. You can't see any blood vessels tracing through here, completely avascular. That's just the air sitting inside the lung. On the other side, nice little vessels. You can trace them all the way out to the edge. Mediastinal shift, trachea's off to the left. Heart's probably sitting way off to the left. So this has got signs of tension. Needs urgent decompression. I don't know how they managed to get a CT without having a tube in, but they did. Again, you can see how much that pushes the heart across. You know, you've got your atria sitting in here and they're going to get very squashed. You're going to have trouble getting blood back to your heart. Okay. So hydropneumothorax, perfectly straight line. It's important to recognise because I have seen cases where the only thing I see on the chest x-ray is a perfectly straight line right down the bottom. I can't see the actual pneumothorax. But if I see a perfectly straight line, I know there must be a tiny pneumothorax as well. Okay, so identifying that straight line can be important. 17-year-old male with chest pain. This is the more standard kind of thing you're going to get for a pneumothorax, one that's not in tension, and you're trying to identify, have they got one, have they not got one. The key is obviously in an erect patient to be looking up the top. The air is going to sit up the top of the chest. And what you're looking for is the actual pleural edge. So you see that thin white line. It's a very, very thin white line. It's got air on one side, it's got air on the other, just a very thin line. Okay. On the outside, there's no vessels. You look in this intercostal space here, there's no vessels. On the other side, you can see little vessels traversing around in there. So a small apical pneumothorax. On the other side, they've actually got one as well. Very thin line. You can actually, with the ribs, the way the ribs go, you can often get that pleural edge may follow very closely to a rib and make it hard to identify. You need to zoom in and really have a good look and you'll see that little edge there. Okay, so small bilateral apical pneumothoraces. The key is that vessels, no vessels go beyond it, okay, and try and find the little pleural edge. This patient might be mistaken for having a pneumothorax because you can see this line coming right down the edge of the chest. But as I said before, it should be air on one side and then a very thin line and then air without any vessels. You can see vessels beyond this, okay? And you can see this line kind of gets dense It's quite thick, dense line, and then it suddenly stops. That's a skin fold. So the patient's lying there and their skin, they've got very floppy old person skin, and it's creating that artefact on your film. So not to be confused with a pneumothorax. But go back to the principle of air on one side, air on the other side, very, very thin, the pleura is tiny, okay, and then no vessels beyond it. So not a pneumothorax. This is your classic, you might get it in a medical student exam or your ED exams. You're going to get given this film and you need to have a very down pat kind of answer in terms of what you're going to do. This is a tension pneumothorax. I want you to take note, obviously we've got the lung collapsed down, the pleural edge is exposed, there's no vessels out here. So everyone's going to spot the pneumothorax. I want you to take note of the mass effect from it, the signs of tension. See, this hemidiaphragm is way down compared to the other side. Okay, so the hemidiaphragm is getting pushed. Spacing between the ribs, as I said earlier, with our collapse, it gets down. With increased volume, the spacing increases. Okay, smaller on this side. The shift of the mediastinum trachea is over here. The whole of the heart is pushed over. Okay, stick in a tube, save a life, decompress that chest. Trachea comes back to the midline. A third of the heart back on this side, 2/3 on that side. Look how far that hemidiaphragm's come up. Just appreciate how much tension there is inside that pneumothorax to push that hemidiaphragm down that far back into the normal position. There's still some residual atelectasis in the lung. It takes a little while to re-expand. That's in the lower lobe because I can't see the hemidiaphragm. Here's a question from someone overseas, Ahmed in Egypt. He said, how can I detect a pneumothorax in chest radiograph in supine position? I usually pick up tension pneumothorax and miss a mild or moderate pneumothorax. It's a very good question, and it's very easy to miss a pneumothorax in a supine patient. ED physicians will take great delight in telling you that they can spot them on ultrasound very easily, and I think that is true if they've practiced it. So using your ultrasound to detect a pneumothorax in a supine patient is very good. On X-ray, the main thing you're looking for, other than the fact that you can see a pleural edge in this patient, but imagine if you couldn't see that pleural edge to know there was a pneumothorax, you're looking for this lucency down here in the costophrenic recess. It's called the deep sulcus sign. Okay? Normally you see just that very thin recess going down. This one's very expanded, hyperlucent. It's called the deep sulcus sign. That's a sign of a posterior pneumothorax, of a supine pneumothorax. It sits in the anterior basal region of the chest, the air. Here's a nice example from my trauma course. Beautiful air bronchograms. These are the best air bronchograms you'll ever see. Look at that. So that patient, you might look at this in a trauma patient and go, oh, they've got a massive hemothorax on this side because they've got heaps of opacity, but it's not. This is alveolar. This is hemorrhage within the lung. Okay. Down in the base here, see how it's more lucent? Down here, can't see that recess. It's all deepened. That's a deep sulcus sign of a supine pneumothorax. When you correlate it with the CT, here's where that pneumothorax sits. Look how deep it goes, right? So that is the sign on a plain film, but it is relatively insensitive, very easy to miss a pneumothorax in a supine patient. ED physician, get your ultrasounds out and have a go. Nice air bronchograms. That's a picture just showing when you're supine, the air collects anterobasally. All right. Now this is the kind of chest X-ray. There's a patient presenting with some shortness of breath and a bit of chest pain. This is the kind of chest X-ray that you often might call as normal because you might be missing some subtle findings. I spoke earlier about the hemidiaphragm and not being able to trace it across the midline when it touches the heart. This one you can probably start to trace it along there. You can also see here, this is a triangle of epicardial fat, and then you can see the actual margin of the apex of the heart there. You don't usually see that. And as you come up here, you see this fine line of air sitting outside the aorta, some streaky opacities going up next to the great vessels and next to the trachea, up into the neck. So this is a case of pneumomediastinum. Just have a look at the CT. They're going to be very subtle. Most patients presenting with pneumomediastinum are going to be asthmatic, younger patients. They pop a little bit of some into the air into the interstitium around the lungs, and then it tracks up through the mediastinum up into the neck. Okay, but you can see the origin of that that continuous, what we call the continuous diaphragm sign, you shouldn't be able to see the diaphragm all the way across. That's the origin of it, air sitting in the mediastinum. You can see exactly why we could see the apex of the lung, so rounded. Okay, air next to the aorta, streaky opacities, streaky lucencies going up into the neck. And it does come at this interstitial emphysema. It comes around the bronchi and tracks back up into the chest. Now, a lot of people think, you see pneumomediastinum and you want to work out where's the air coming from. Is it coming from the airway or is it coming from the esophagus? That's the other thing that can put air out into your mediastinum. When you have air coming from the airway, the mediastinum stays relatively clean. There's no fluid in it. It's just air, okay? And the pleural space stays nice and clean. If you rupture an esophagus, it is badness. I spoke earlier about the mediastinal fat and being able to see it around all of the structures. Here's just completely infiltrated with fluid, okay, throughout the mediastinum. You can't make out the edge of the aorta compared to the edge of the esophagus, right? And you've got fluid tracking out into both pleural spaces. Okay, so this pneumomediastinum is due to a ruptured esophagus. The other pneumomediastinum due to ruptured airway in a patient with asthma. All right. So if you're looking at your plain film and they've got pneumomediastinum but they've got perfectly clean costophrenic recesses, no pleural effusion, that's going to be an airway. These people are very unwell if you've ruptured your esophagus.
Can I make one little comment about another risk group that we do see it in sometimes is people who, they call it insufflating, so people that are snorting coke or smoking bongs, people that are sucking things in and then have chest pain. It's not unusual to get people on amphetamines with chest pain, but take an extra close look at their chest x-ray. If they're thrashing around with chest pain after using drugs, it's another time we see it. So
that increased pressure, and we see that iatrogenically as well in patients who've been intubated, positive pressure. So a quiz case, 25-year-old woman with sudden onset pleuritic chest pain. This is a CTPA that's positive for PE, and I asked you guys to find it. And I think this is a skill that all emergency doctors probably should have. It's something in radiology where you've got one task. All you've got to do is look at the pulmonary arteries, follow them out and try and find where the contrast is no longer getting through, okay? So it's worth practicing. You do need to trace each vessel out itself. Alex was our winner. Where is Alex? Yeah, he's coming down. So, first thing I'm going to say about CTPA is, especially at our institution, the way the images come across to our packs, the window and levelling of the scan is not appropriate for assessing for a PE. Usually it's very, very bright contrast and you get a lot of flaring of it. So this is what it comes across naturally like, okay, very, very dense contrast. And here's what it looks like when you window it down a bit, okay. See all that swirling? See how you can detect all this swirling of blood in the ventricle? That's what you want to see. You want to be able to see the fine detail of what's happening on intraluminally within these vessels. You don't want that flaring out, complete whiteout, okay. So that's the first tip for CTPA. Alex, do you reckon you can drive it? Yeah. Good man. So he's going to follow the vessels out.
Just there. So there's bright contrast and then there's not.
Correct, yep. And you see any other ones? Second one, there's a... No. That one's a bit hard. Try your coronal MIPS. So the other thing that often you'll use to find it is these maximal intensity projection images. It kind of brings the vessels into a much more vessel-like view for you, and you can try and find the filling defect. Yep, so there you go. There's an abrupt cut-off of the contrast, and then a second one there. So this is 2 subsegmental level pulmonary arteries. I want you to appreciate how small those little vessels are and how sensitive a CTPA that's timed well, how sensitive it is for finding those tiny little things. Let me point them out. Take your prize, Alex. Thank you. So not many people were able to find this. Maybe they didn't have the time to look through it. But what I want you to do with your CTPAs is you need to be looking at each vessel, tracking it right out to the periphery, coming back to the hilum again, and then tracking the next vessel out and making sure it has uniform contrast throughout it, okay? So each one you need to track forward and back, forward and back. So if you see a radiologist looking at a CTPA, they're going to be going up and down as their eyes are following one vessel, then the next, then the next, okay? In this one, you need to follow it down, okay? And then appreciate that here, there's some good contrast in the vessel here. Next slice, dark, okay? And then when we're going this vessel here, here it is, it's about to branch, nice contrast in it. This branch, dark. This branch got nice contrast going into it, okay? So significant, because if you find these small PEs, they're going to get treated. They may be about to have a large PE, okay? That's why CTPA is an important test, but if you don't have correct timing, if you have a motion artifact or the timing of the contrast is off, you really can't detect those subsegmental level emboli. The next case is a patient who's got massive bilateral pulmonary emboli. Again, you're just looking for that contrast cutoff. We call it a filling defect within the vessel, okay? Not all of these are completely occlusive. You can see some contrast getting through into some of the vessels, okay? The reason why I put this case in there is to look for the features of right heart strain, okay? Let's go back to our previous patient. You can see here, this is the normal appearance of the right ventricle. See how the left ventricle, which is this one, the interventricular septum is bulging towards the left ventricle. It's because the pressure on this side, the systemic side, is much higher than on the pulmonary side, right? So it bulges in there. That's the normal arrangement. If we go to our patient here who has massive bilateral pulmonary emboli, have a look at that interventricular septum. Okay, it's bulging into the left ventricle. There's expansion of that right heart. The right atrium is big, the right ventricle is big. So there's signs of right heart strain on your CTPA. So we'll often report those. You'll also be able to detect that with echo as well. So again, a good ED physician is going to be one who can use an ultrasound probe. And so if you've got a patient who you think's unstable, might have a big PE, let's have a look quickly, try and have a look at the heart. Is the right heart dilated? If yes, I don't necessarily need the scan to know that they've got a big pulmonary embolus. Okay, 75-year-old male presenting with chest pain. No plain film for this one. The plain film's pretty much going to be normal. Okay, I didn't emphasise it at the start, but mediastinal things, chest X-rays aren't fantastic for. Okay, if you have a normal chest X-ray and chest pain, all right, then you need further investigation with a CT unless you can explain it via an infarct or something like that. So this patient has a dissection of their aorta. This is the true lumen here with the nice bright contrast in it, the false lumen with the less dense contrast, and you can see the intima that gets stripped away, okay, as the blood is dissecting into the wall of the vessel. It dissects all the way down, right through into the abdominal aorta in this patient. This is not that important, the distal extent, okay, but the proximal extent is very important. There's a Stanford A, Stanford B classification. If the dissection is in the descending aorta past the level of the subclavian artery coming off, then you're talking about Stanford B and conservative management with blood pressure control, because hypertension is the cause for these. If it's involving the great vessels where they're coming off, this one clearly is, these are the great vessels coming off here, the neck vessels, then that's a Stanford A, and that means it's involving the vessels or the aortic or the ascending aorta. Problem is it can dissect all the way back, right, down to the aortic root, right? This is where your coronary arteries come off. Can you see that little vessel there, right coronary artery, and a left coronary artery coming off here? See how the dissections come all the way back to those, so you can block off those arteries. You can also leak blood out into the pericardial space, which this patient has. See that thick? So that's the wall of the ventricle there. Then there's blood sitting in the pericardial space. So this patient may develop a pericardial tamponade from their aortic dissection. This is pre-terminal kind of stuff, needs urgent attention. The final thing I'll talk about with the aorta is often you might not dissect, but you might get one of these penetrating ulcers where you get leakage of contrast out. That's a pseudoaneurysm. If there's a hole in the wall of the vessel, contrast leaking out, pseudoaneurysm rather than a true aneurysm where it's just a bulging of all layers of the wall. And you can see how it's got periaortic hematoma. I spoke about looking at the mediastinal fat earlier. You usually have the aorta, then your imperceptible wall, and then nice black fat sitting next to it. Look at all this periaortic hematoma. Okay, so this patient has a ruptured ulcerating plaque. That's the end of the chest session. Do some more tweeting. I don't know if we've had many tweets yet. And 3 minutes, 4 minutes, and then we'll get into the abdomen. Have a stretch.